We do want to thank our sponsors for tonight. So, Erin's going to be putting up a slide, but we can't do any of this without the support of our education sponsors. And tonight is presented by West Pharma. They are our lead presenting sponsor, and our supporting sponsors, Daiichi Sankyo, Merck, and Lilly. Again, we are most grateful. We have over 40 of these speaking engagements, speaker series, Ask the Experts, virtual hangouts a year. And this enables us to bring on speakers that are just the top in their field. One of them that you're going to meet tonight. So thank you to them. We appreciate you greatly. And thank you for doing that shout out for them, Erin.
Absolutely. Okay, shall we jump into it, Sue?
I think we jump in. Absolutely. Okay. I'm going to put you front and center, Erin.
Wonderful. Thank you. So before we bring on Dr. Malik, one thing that we thought would be really helpful just to sort of start off our presentation this evening is understanding, as Sue said, that the discussion around weight and obesity, particularly its link with any sort of health conversation, is a sensitive topic for a lot of us. And we know that it can provoke a lot of emotion. I know that I hear that so often when we connect with our Unite for Her members. I hear the frustration. I hear the hands going up. You're just not really sure what to do, sort of the confusion around it. But we have a responsibility to our members to bring you information, to bring you experts that can teach us, right? That can also have open conversation and answer your questions. So that is what we are doing this evening. So we hope that we have someone that is a true expert in her field to share the science behind what is this link, to ask your questions. But we want to make sure that you know that there is no judgment in this. We want you to ask questions. We want you to be open, and hopefully that you will leave tonight with information that will only help you make the best decisions for you and for your treatment with your medical team. So know that we are just here to support you. We hope this is helpful. I think it will be. And we're really looking forward to good questions and good discussions this evening. So with that being said, I do want to introduce our speaker this evening because she is truly incredible. So Dr. Manmeet Malik is an assistant professor of clinical surgery at Weill Cornell Medicine and director of the Breast Center at New York Presbyterian Queens. She is a board certified surgeon who specializes in treating breast disease. She's a fellow of the American College of Surgeons and a member of the American Society of Breast Surgeons, and has presented research on breast cancer and surgery at many national meetings. Dr. Malik, thank you so much for being here with us, for sharing your time, for sharing your knowledge with us. We're really looking forward to this evening.
Thank you so much for that very kind introduction. And thank you, Sue and Erin, for inviting me to speak this evening. As Erin had mentioned, this is a sensitive topic, but I think it's really important to understand the science behind it and educate, because I feel like if women are aware, and men as well, about the complex interplay that in the environment in which we live in, I think it can be helpful to make some lifestyle changes that not only can potentially decrease your risk of developing multiple different cancers or disease recurrence, but also your overall health. And I think it's really important that patients are aware that there's something that they can actively engage in to improve their potential outcomes and their overall health. And so, I just want to make it clear, and I'll reiterate throughout this presentation, that if someone is overweight or obese, that did not cause your cancer. It did not cause a cancer in your loved one. But there are these links that may exist that we can kind of address to help decrease that potential link between obesity and different types of cancers. And I'm a breast surgical oncologist, so that's what I'm going to focus on this evening. So with that, I'm going to share my screen and we'll get into the presentation. I will try to keep the presentation relatively brief so that we can have enough questions, enough time for questions and answers, because I feel like there are a lot of unknowns and it'll be good to engage in dialogue regarding it. So let me share my screen. No matter how many times we do Zoom, it's like the first time every time. Okay.
No, I feel the same way.
All right. Are we good? Everyone can see my screen? Excellent.
Gotcha.
Okay.
Yep.
So once again, I'm Dr. Manmeet Malik. I'm the director of the breast program on the surgical side at the New York Presbyterian Queens campus of Weill Cornell Medicine. And so we're going to start by definition. So how do we define obesity? There are two main ways in which in the medical world we talk about obesity. And what you've probably heard the most about is what we call BMI, body mass index. And that's calculated using a patient's height and weight, and usually gender is incorporated in that as well. It's not the best way to look at obesity and the different stages and levels of obesity. There's another method which is called body fat distribution, which looks at where does the fat reside in your body. And that means subcutaneous. So when someone's visually looking at someone and they are describing them as overweight or they feel overweight, that's usually the subcutaneous, the fat that lies underneath the skin, between the skin and the muscle. And then there's visceral fat, which is very important to make that distinction. Visceral fat is the fat that's internal around the organs. And I'll show you an image of that in a few slides to get a better understanding. And body fat distribution is actually a better predictor of health hazards than BMI, because you can be overweight, but if you're really tall, then it kind of puts you into the normal quote unquote BMI category, but that doesn't really tell us much about your overall health and well-being. So BMI is kind of put into these different categories. So normal weight, overweight, and then there's different classes of obesity. And as you go from a lower number to a higher number for BMI, it's class 1, class 2, and class 3. But as I mentioned before, the BMI numbers don't take into account the percentage of body fat versus muscle. And you may have heard it around in social media or conversations with friends and family members that muscle weighs more than fat. It may not weigh more, but it definitely weighs the same amount. But 1 pound of fat takes up more space than 1 pound of muscle. And so that's the appearance that comes into it. But if you could have two people with the same BMI or weight, and one person is much more muscular and looks larger from a visual perspective than someone who doesn't have as much muscle mass but has more fat content in their body. And this is kind of a nice depiction of that. So this is done based from a New York company, a startup company that developed this depiction for Cosmopolitan magazine on how 6 women with the same BMI can look physically very, very different. And in this visual, each body weighs 145 pounds and is 5'7" and has the same BMI of 22.8. And you can see that the body types are very different: pear-shaped, round, centrally larger, top heavy, the different descriptions that go around, but all these patients have the same BMI. So if we're using BMI as an indicator of being of a normal weight or not, it's not actually that accurate. And so this is a nice depiction of what I mean by subcutaneous fat versus visceral fat. So if you look at the image over here where I have my cursor, this is a metabolically unhealthy patient from a biological standpoint. So you can see that there's not that much fat on the sides of the body, right? But you can see much more underneath the liver. That's what this organ is, the liver. And you see that there's much more liver fat around the liver. And this is considered a metabolically unhealthy patient. And we could talk about that in a little bit more detail from a biology standpoint, what that means, versus a metabolically healthy individual who actually may have more subcutaneous fat, but less fat around the liver. And then in this image over here on the right, you can see there's multiple things that account for this. It's energy intake, it's genetics, it's hormonal status, it's what you eat. And same thing with a metabolically healthy person, there's a lot more here on the side around the hips and the thighs, but not a lot around this liver. And then when you're looking at a metabolically unhealthy patient, it's kind of the opposite, a lot more around the liver. So visceral means organs, so a lot more around the organs, but a lot less in the periphery. And then it kind of shows that either way, if you have energy expenditure, you're burning that fat around the muscles, whether it be the subcutaneous muscles and the subcutaneous fat, or the visceral in the organs. Sorry, I've done something to my screen, so just give me a moment. Okay. Okay, that's better. Okay, so body fat distribution. So this is something that you probably haven't heard much about, because BMI is just an easy thing to calculate. You can even just go online and find a BMI calculator, put in your height and your weight, and a number gets spit out to you. Body fat distribution is a lot harder to measure, which is unfortunate because it gives us a lot more information. So how do we measure it? There's multiple different ways. There's waist circumference. And so sometimes if any of you have been to a center where they'll look at weight or measurements, or you go to a gym and you're starting off in a training program or Weight Watchers or something like that, they may do some measurements. This is actually a better indicator of how you're doing in your training and your weight loss when you measure your waist circumference. There's also a measurement which is a waist to hip ratio. There's also a waist to height ratio, and then there's scans. So scans are actually the best way to do it, but that's when insurance gets in the way, because these are not actually approved to look at body fat deposition. So DEXA scans, you all may have heard of. So DEXA scans are what we use to measure osteoporosis. So if any of you are on a medication called an aromatase inhibitor, in that group, or it's anastrozole, letrozole, exemestane, to give you a few examples, your medical oncologist or your primary care doctor may be ordering a DEXA scan every 2 years. And that's to look at your bone density, because that medication can cause bone loss, which is osteoporosis. And that helps the medical oncology or your medical oncologist or your primary care doctor take a look at your bone health. And, are your bones okay? Is the medication affecting it or not? So DEXA scans can actually be used to look at body fat deposition, but it's not usually indicated for that reason. Same thing with CAT scans to look at the internal organs, and PET scans, which incorporates a special dye that's injected into the vessels that, along with a CAT scan, can look at the whole body from skull base to mid thigh. So all of these are tests that you may have heard of, and they're great to look at body fat distribution, but that's not really what they're approved for. And so unfortunately, they can't be used routinely for those reasons. So how common is obesity? We've talked about what it is and the different ways it can deposit in the body, but how common is it? So according to the CDC, in 2011, 27.4% of adults in the US had obesity or severe obesity. And in 2020, that number increased to 31.9%, and it continues to be on the rise. These numbers are also prevalent in children. So when you look at the ages of 2 to 18, the numbers, the percentage of obese children in the United States has also increased over time. So this is important, not just for the adults in the United States, but also to implement healthy eating habits and lifestyle changes from an early age, so that we can prevent potentially and mitigate the risk of some of the things that we're going to talk about today. And to get there, so we all know that obesity has effects on the body. So there's what's called metabolic syndrome risk factors, so it can increase your risk for type 2 diabetes, for heart disease, for fatty liver disease. So the pictures that I showed you were from the prior slides, were fat deposits around the liver, but you can also have fat deposits inside the liver, which then they don't allow the liver to function as well as it should function. Kidney disease is another one, gallstones, gallbladder disease. And then the direct effects are, it can affect asthma, it can cause or worsen asthma, sleep apnea, something called the hypoventilation syndrome, which is pretty much because of the weight on the body, the lungs can't expand well and aerate and exchange gas, osteoarthritis, joint pains, back pain, and gout. So now getting to obesity and cancer. And once again, I want to preface that obesity and being overweight does not cause cancer. It can increase your risk. There's a theory, this is all theoretical, that it can increase different kinds of cancers, and it can increase your risk of recurrence if you've had a cancer. But this link is just starting to be developed. It is very, very multifactorial. If we knew what caused breast cancer and different types of cancer, we would hopefully have a cure for it. So I just want everyone to understand that there is nothing that you did or did not do to make your cancer if you are living with cancer or know someone who is. We don't know what causes cancer, and there's a lot of research and development that's going into that. And so it's important to educate ourselves and the community to know what can we do to potentially decrease our risk. And that's what we're going to talk about in the next few slides. So there are 13 cancers that are associated with being overweight and obese. Brain cancer, meningiomas, cancer of the esophagus, multiple myeloma, which is in the bones, kidney disease, uterus, ovaries, thyroid, breast, which is what we're going to focus on today, liver, gallbladder, stomach, pancreas, colon, and rectum. Sounds like a lot. But you know, it's important to educate ourselves about this. So specifically about obesity and breast cancer. So obesity was first reported to have an impact and a potential interaction on breast cancer diagnosis and outcomes in 1976. That was not a long time ago. So this is all new data that we're obtaining that probably we won't have really real answers on for another 20 to 30 years as we get more information and more testing to see if there is a true link, just because there's so many other factors that goes into it. But from the information that we do have, the links are showing that it may be associated with worse outcomes. Obesity is an established risk factor, which we know, which we've spoken about earlier this evening, for metabolic syndromes like type 2 diabetes and heart disease. And those are actually the main causes of mortality in women with early stage breast cancer, not the cancer itself. So addressing obesity is not only something to mitigate your breast cancer risk, but also for your overall health, because as the data shows, the main cause of death in women with breast cancer is not the cancer itself. It's the other disease processes that can come along with obesity. And the reasons for the adverse effects of obesity on breast cancer specifically are numerous and very complex. And this is one of those complex slides. So obesity and its downstream effects. So in the center, you have food, nutrition, obesity, and physical activity. And these can affect multiple things. So DNA repair is how your body, how the cells repair themselves. Proliferation, how they're growing. Hormone regulation. Differentiation, which means how the cells, when they're first formed, how they're dividing and going into different organ systems. Inflammation and immunity, apoptosis, which is cell death. And so the whole body is about cell growth and cell death. But if you don't have appropriate cell death, that can lead to the overgrowth of cells, which can then potentially go into overgrowth of normal tissue, which then leads to cancerous tissue. Cell cycle, which is another part of that cell growth and death spectrum. And then carcinogen metabolism, how our body breaks down harmful agents that we breathe in, whether it be pollution or something in the environment or something that we eat, how our body maintains and regulates and gets rid of the bad things and keeps the good things. And this is a very busy slide just to show you that there are multiple studies from an epidemiological standpoint that show the potential link between obesity and breast cancer. So even though this is relatively new, there's multiple studies that have been done since 1976 to kind of corroborate and correlate this theory that has been out there. And biological factors. And so fat is a metabolically active tissue with high levels of aromatase enzyme, which converts androgen to estrogen. So those of you who have heard of or are taking an aromatase inhibitor, the reason that that medication is given, because it actually blocks part of this pathway. It's an aromatase inhibitor, so it inhibits that enzyme, which converts these androgens to estrogen. So just to make it a little bit more relatable, cholesterol. We all know cholesterol is not good for us. Cholesterol comes with increased fat intake. Some patients just genetically have high cholesterol levels. And that goes down into a couple of different metabolically active things in the body. And one of them is this thing called DHEA, which is an androgen, which then goes into the hormones testosterone and estradiol. And what causes the conversion from these, a byproduct of cholesterol, are these hormones testosterone and estradiol, and that's the aromatase enzyme that I had mentioned. And that's what we block when we give aromatase inhibitors to decrease the estradiol, which is the estrogen, and its effects on breast cancer cells. And so that's why we do that. And in younger women, we give a medication called tamoxifen, which just blocks all the estrogen in the body. So it works a little bit differently, but it still has the same end result of blocking estrogen in the body. And so excess estrogen production from fatty tissue in the body has been proposed as a possible mechanism for the adverse outcomes that we're seeing in obese women with breast cancer. And when we look at the adipose tissue, so adipose is just another term that we use for fat. So when we look at an adipocyte, which is kind of like these little white bubbles that are the fat cells, and it goes into this kind of very, biology 101 image here with something called crown-like structures, and pretty much a really scientific way of depicting what's going on. But what I want you to take away from these slides is this word inflammatory. So inflammation is a big part of what we're seeing with obesity and breast cancer. So obesity produces inflammation in these fatty tissues, and that activates this cascade of further inflammatory mediators that have been shown to increase cancer risk. And the mechanisms of obesity-driven breast cancer, as you can see here, are very complicated. In addition to the inflammation, it also affects insulin and the way our body processes insulin, which is, so this is another reason why the obesity and the diabetes link exists. And why this is important is because if we know that obesity may increase a woman's risk of developing breast cancer, it's going to affect how we screen, diagnose, and treat these patients. And so information is power, because once we know that this exists, we can do something about it. So there is a correlation between obesity and what we call TNM stage at diagnosis, which is tumor size, if lymph nodes are involved and how many, and M is for metastatic disease. And what we've started to kind of see a trend of is an increased lymph node involvement and metastatic disease in women who are obese with breast cancer. But it's unclear whether that's due to difficulty in screening these patients and reduced adherence to mammographic screening in obese patients, which is something that's been shown to exist in data, that obese women have do less screening of their breast than non-obese women. And that's just the data. Unsure why, but that is the data. And once again, it's when you have a large breast, is the whole breast being imaged? Are we able to do an ultrasound of the whole breast and take a really good picture of the breast and the lymph nodes? And those can create some diagnostic difficulties. And so is that the reason that there's more advanced disease, or is there really, really, truly something biological that is causing this link between obesity and breast cancer? There's also an increased risk of surgical complications for obese breast cancer patients. And I have breast cancer patients here because that's what we're discussing, but it's actually for all patients undergoing any type of surgery. There's an increased risk of complications with anesthesia and getting a breathing tube in safely. There's an increased risk of bleeding complications and surgical site infections. That's why a lot of patients that are obese or overweight do get preoperative antibiotics, so an antibiotic that goes into the IV before the surgery begins. And patients with a BMI over 30 were noted to have more postoperative breast asymmetry and a less favorable cosmetic aesthetic result. Obese women may also not be candidates for reconstruction because data shows that reconstruction in obese women can potentially have more complications secondary to the comorbidities that come with it. If a woman who's obese has diabetes or high blood pressure, just like someone who smokes, it can increase their risk of surgical complications. Lymphedema is a big thing also. So lymphedema is a very tricky thing that we deal with as breast surgeons because it can happen right after surgery, or it could happen 20, 30 years after surgery. And there are known risk factors associated with the development of lymphedema. And those include the number of lymph nodes removed during surgery. The more lymph nodes we remove, the higher the chance of lymphedema. Development of surgical complications such as an infection or a seroma, which is a seroma is a fluid collection that develops after surgery. And so if someone is obese and they're more likely to develop an infection, then that's going to potentially increase the risk of developing lymphedema in the future. The use of chemotherapy, radiation, and comorbid medical conditions in general, including obesity, are going to increase the risk of lymphedema. And things are changing. There's a lot of development and research in lymph node surgery when it comes to breast cancer. And those of you that have maybe treated or know someone who's treated 20 years ago, what we did with the lymph nodes is very, very different than what we do with them now. So I think it's going to change what we see with lymphedema going forward because we do a lot less lymph node surgery because over time we've realized that it may not have as much benefit as we've thought in the past, and that radiation actually may be better to control lymph node disease than surgery. There are ongoing clinical trials evaluating that right now because if we can get the same results with radiation that we would get with surgery, but there's less side effects, including less risk of lymphedema, and that's probably what we should be doing. So that's currently under investigation. And then barriers to chemotherapy. So obesity is associated with a reduced response to the therapies that our medical oncology colleagues give our patients. And that's possibly related to the dose-limiting toxicities, meaning that if there's only a certain amount of dose you can give a patient before it gets into what we call the toxic or dangerous zone. But then are we undertreating these obese patients because their body fat distribution, their overall, their size may require higher doses of chemotherapy, but those need to be limited secondary to the potential side effects of the medication. So should we consider certain medications in certain patients to be weight dependent, which we do a lot of times in children where medications are given based on their weight, not necessarily their age, because you need to be able to get to that appropriate dose. And so do we need to tailor that a little bit more? And that's something that's being looked into. And in the adjuvant setting, meaning after surgery, full doses of chemotherapy are associated with a greater improvement in overall survival, which makes sense. And so do we need to be giving more chemotherapy in terms of the doses of the medication to patients who have a higher BMI or body fat deposition? Obese And as I just mentioned, obese patients require higher doses of chemotherapy to achieve those therapeutic levels of tumor suppression, but can we do that safely? Endocrine therapy is what we were briefly talking about before with the aromatase inhibitors and tamoxifen. The therapeutic dose of individual medications is fixed, regardless of weight or body surface area. And I always find this fascinating because the doses that we give here in the United States are different than the doses that they give in Europe. So how did they come up with these? I'm not really sure, but it is fixed here in the United States. And the Austrian Breast and Colorectal Cancer Study Group, which looked at 12 different trials, including 1,800 premenopausal women with early stage breast cancer that were treated with these medications to decrease the estrogen production from the ovaries, and receive tamoxifen or anastrozole. And what the study showed is that overweight women that were assigned anastrozole, the aromatase inhibitor, had a 60% increased risk of disease coming back and death compared to their normal weight survivors. And so this is definitely something that warrants more research to kind of see, well, if anastrozole is blocking this agent that's coming from fat cells, but if an overweight patient has more fat cells, it makes sense to give them a higher dose. We just need data to show us that we can do that safely. And so the benefits of adjuvant chemotherapy and or endocrine therapy were significantly less in this study in obese population. And this was independent of tumor size, lymph node involvement, and other features of the tumors, including the receptor status of that specific tumor. And so where do we go from here? So we know that there is sufficient evidence to support that obesity is a risk factor. And I want to say again, it doesn't cause it, but it's a risk factor for the development of breast cancer and is associated with increased mortality. And we know that there's a molecular link between obesity and resistance to treatment. And we know that suboptimal dosing of chemotherapies and endocrine therapies can exist in this patient population. So what we need to do going forward is there are medications available. And so please, you can, if there's something that you think would pertain to you, you can speak to your healthcare provider regarding it. But Metformin is a medication that's used to treat diabetes. It's a very well-known medication, and it has also shown benefit to reduce risk of breast cancer. And that plays into the whole pathway of inflammation and insulin resistance and comorbid conditions in women who are obese, and how this medication can then combat their diabetes, but even if they're not diabetic, can potentially reduce their risk of breast cancer. And it's actually been starting to be used for weight loss in general. We need to do trials looking at immunotherapies in obese patients, as they may respond better if they're not gonna, if the dosages of chemotherapy are gonna be limited secondary to the side effects. We need to look into other things such as immunotherapies. We also need to identify metabolically obese patients who are normal weight, which goes back to one of the first slides that I showed about body fat deposition, because they could look normal weight, they could be normal weight, but there is organ, what we call visceral fat, and that makes them a metabolically obese patient, even though BMI is normal. And we need to do more studies and meta-analyses, which is looking at multiple studies in aggregate to establish the link between obesity and breast cancer progression, response to therapies, and metastatic disease. And so steps, what can we do? What can we do as healthcare providers and as patients to try to mitigate our risk, to decrease our risk? And it's easier said than done, but it's to maintain a healthy, balanced lifestyle. There's nothing, I tell my patients this every day, there is nothing that they did or did not do to make them have breast cancer. The important thing is that information is power. We can diagnose it, we can treat it. I think we need to change how we talk and think about specifically breast cancer. As most of you here know, 1 in every 8 women in the United States gets breast cancer, but it is very treatable if caught early. And so screening mammography, all of that stuff is very important, breast exams. But what can we do as individuals to potentially decrease our risk? And that comes down to diet, exercise, and mental health. So diet, it's not a one size fits all. There's different ways to change how you eat. Some things work better for some patients, some things work better for other patients. And that's when our valuable, very experienced nutritionists come into play, because they can tailor these things to your lifestyle and to your cultural ways of eating, and the different foods that you may eat at home. And, for some patients, intermittent fasting works. Some patients, small portions work. There's so many different ways to go about it. Exercise is extremely important. We do have data that a woman who exercises, and we're not telling everyone to go join a gym, 30 minutes, 5 days a week is what you need to do. 150 minutes a week of something to get your heart rate up and sweating. So if that means going for a brisk walk, if that means going for a jog, if that means baby steps to get there, to slowly increase what you can do. It's what I tell patients who are doing arm exercises. You got to climb the wall. And then when you get there, you go a little bit higher. And then when you get there, you lean a little bit forward. It's baby steps. Because patients are like, I can't go to a gym. I don't have time for that. I can't pay for that. You don't need to. Simple things. Take the stairs instead of an escalator or an elevator. These small changes in your day-to-day routines can make a big difference. Mental health is extremely, extremely important. Life is chaotic, as we all know. And all of this kind of ties down into what I call hormonal homeostasis. And what I mean by that is maintaining a hormonal balance as best as you can. It's not easy, but if you can tackle this by piece, little changes in diet, a little bit more physical activity, a session for just relaxation, deep breaths, meditation, whatever you need to do to calm yourself, and try to bring those stress levels down is beneficial, not only for your hormonal homeostasis, but for your overall well-being. And that can be different for different people. I've tried meditation, doesn't work for me, but it works really well for other people. And so I think it's valuable to get information from friends and family and try different things, but it may not work for you, and that's okay. You can try something else. But I think it's important to incorporate these things into your life and your day-to-day to try to maintain that hormonal homeostasis, because as you saw on some of the biological slides I showed you earlier, it's all about balance. It's about the inflammation and the imbalances in that structure and the hormones in the body that can lead to this haywire of our system, of our immune system, that can potentially then increase our cancer risk. And with that, I will end, and we can kind of address some questions that you all have. And thank you very much for allowing me to share today.
That was wonderful. Thank you so much for all of that. We have some questions coming into the chat, so I'm sure we'll have great conversation. I just want to say one thing. That last slide, Dr. Malik, that you mentioned, hormonal homeostasis. I love that you said that, because oftentimes when our nutrition team connects and we're asked specifically about food and hormone balance, I use the analogy of I liken hormone balance to a symphony. I often compare it to a symphony, right? There's different parts of it, and everybody's got to work together to create music. And that's sort of how I see hormones. We have all of these different things that contribute to it, and they're all, they all contribute to that homeostasis. I love that. Wonderful. So if you want to take a quick peek at the chat, I think we'll just start off quickly. So one of our members just lost audio. If you wouldn't quickly just reiterating what you were saying about exercise and its importance, about the evidence behind exercise, please.
Sure, happy to do so. So there's so much that we don't know about breast cancer, but we do know, and we do have data that women who have had breast cancer, those women who exercise 150 minutes a week, so it's easiest just to say 30 minutes, 5 days a week. So pick your days, 30 minutes, can decrease your risk of breast cancer recurrence. And there's actually a large clinical trial that just completed. So we're waiting for the data to come out. It's called Be Well, which they incorporated nutrition. You've probably heard of it, Erin.
Yeah, we've had some members that were in that trial. Several years ago, we worked with some of our members that were in that clinical trial.
Yeah, so we're waiting for the data to come out and be analyzed from that trial, but it looked at nutrition and exercise, and to see what the long-term effects of that was. But we do have lots of data that shows that small change, 30 minutes, 5 days a week, 150 minutes a week, something to get all you got to do, it's going to be different for everybody. Someone's heart rate's going to get up and they're going to start sweating just from a brisk walk. Some patients may need to jog or run or do or treadmill or elliptical bike, whatever it may be. So it's going to be different for everybody. So I think it's a good way to think about it, being like, what makes you start sweating and kind of, your heart racing a little bit. And baby steps, we want to work up to that, can decrease your risk of breast cancer recurrence. And honestly, it's good for your overall health. So it's something that I think is really important to incorporate into your lifestyle.
Wonderful. Thank you for that. We also had a few questions just going back to metformin in particular, and just a little bit of clarification. So someone wanted clarification. Metformin is a cancer treatment, or is it used to lose weight? Would it replace an aromatase inhibitor? And then just some questions about whether it can be taken with things like tamoxifen, gabapentin, if you wouldn't mind addressing that.
Sure. So metformin is not a cancer medication. So metformin is primarily used to treat diabetes. It's an oral medication. It's not insulin that has to be, injected or anything like that. It's an oral medication that patients take to decrease the glucose levels in their body, for those with type 2 diabetes. So there is data that it is effective as a weight loss medication. So some medical providers will, especially there is a field of medicine that's called obesity medicine, or metabolic physicians that specifically treat patients from a medical standpoint with obesity and who have tried other methods without success in the past. And they usually are the ones to prescribe this. Primary care doctors, if someone's borderline diabetes, will say, hey, we can, kill two birds with one stone. It'll help control your glucose levels with your diabetes, and it'll also help you lose weight. So there is data for that. So it does not replace an aromatase inhibitor. It is not a cancer medication, but it's used for diabetes and weight loss.
Wonderful. Thank you. I also had someone that messaged me privately that just questioning about Trulicity and breast cancer. Do we have data on Trulicity, and do we know anything in terms of, could that have the same possible effect as metformin?
So Trulicity, I don't want to speak too much about it because I'm not that familiar with it, because I don't prescribe it, but it is used for weight loss, I believe. But that's one of those things. That's why there is a specific field for this, because there's so much that goes into it, and then there's side effects, and so the medications are not suitable for everybody. Some of these medications can affect the kidneys and the liver, so it does have to be given with an expert who knows more about the side effects of those specific medications.
Okay, wonderful. Thank you for clarifying that.
Dr. Malik, I actually had a question for you, because I was so interested in the science between our Australian friends and our European friends, and how we have this limited dosing, but they do not. So are they seeing different results, or could you clarify that?
Yeah, so for example, tamoxifen. So here in the United States, for treatment of breast cancer, the dose is 20 milligrams daily. In Europe, in Italy, they give 5 or 10 milligrams. So they'll either do a 10 milligram tablet or they'll do a 10 milligram tablet, they say, to cut in half and take half of it every day. It's really hard to compare because the levels of obesity aren't as high in Europe. And so it's, are we giving a larger dose here because our patients are more overweight? And so our normal body weight that these trials were done on may be potentially at a higher level than in Europe. There's so many variables that go into it, but the dosing of medications, specifically tamoxifen, is different in their indications. They use either 5 or 10 milligrams for treatment of breast cancer, where we use 20 here. But there was a large Italian study that looked at tamoxifen for treatment of early stage breast cancer. And so that data is now trickling to the United States. So some medical oncologists are comfortable giving a lower dose of tamoxifen for our high risk patients that don't actively have breast cancer, and are sticking to the 20 milligrams for our patients that do have breast cancer until there's a United States study that comes out, because our patient populations are different, so you really can't compare.
Yeah. I think about, we hear so much from our community on tamoxifen, and it really can have difficult side effects and symptoms. And I wonder if that was the case, would a physician recommend a lower dose? Do they do that?
Yes.
So that they could stay on the treatment? Or could that, knowing that they knew the composition of that patient, that they could recommend that off the bat, like without starting so high? Could patients actually ask for that? Do you have patients asking for that, or doctors referring that?
Yeah, definitely. So at the end of the day, something is better than nothing. And we also need to balance the side effect profile, quality of life with what we're trying to achieve by giving these medications. So on the surgical side, I'm not the one prescribing it, but I work very closely with my medical oncology colleagues, and they do drop the dose, especially for stage 0 breast cancer, ductal carcinoma in situ, which we also call precancer. So for those patients, I've seen it much more frequently than we have in the past, and it's because of this large Italian study that came out showing that you could get just as much benefit with a lower dose.
Okay, thank you.
You're welcome.
Appreciate that. We have many more questions in the chat, so I didn't mean to jump in there, but that was very fascinating to me. Erin, you want to keep on going there?
Yeah, we had a couple great questions. Does the risk vary with the level of obesity? And I guess sort of a question related on the flip side. So losing weight and exercising after breast cancer will improve prognosis. Is that correct?
That is correct. It decreases the risk of breast cancer recurrence. So the breast cancer coming back, which then translates into better overall survival and better prognosis. For the first part of the question, theoretically, yes, the more overweight you are, so the higher class of obesity, because if we went back to one of my slides where it was, normal weight, overweight, class 1 obesity, class 2 obesity, class 3 obesity. So if you're in a higher class of obesity, then theoretically you have more fat cells, adipocytes, which can then go into that cascade of increasing estrogen, which then can feed a cancer. So yes, theoretically, the more overweight, the more obese, the more fat content in the body, potentially the higher risk of developing breast cancer.
Okay. So related to that, Cheryl had a great question. So if you lose weight after surgery and are no longer in an obese category and you're taking Arimidex, will the weight loss now make Arimidex more effective?
Theoretically, yes. Yes, because you're taking the same dose and now it's blocking a lower level of that aromatase versus like you have a whole bunch of fat cells that are then trickling down into estrogen. You have that at a lower volume, but you have the same amount of medication combating it, if that makes sense. I remember we're all talking, I just want to clarify, this is all theoretical, based on the information that we have been obtaining through science and studies and our models of how these pathways kind of exist. we're using that framework to then kind of put it in what we're seeing now, but this still needs to be evaluated and investigated further.
Okay.
Terrific.
Yeah. I think Gloria had a great question as well. Can breast cancer lead to obesity?
Interesting question.
Right.
So some of the medications that are used to treat breast cancer can cause women to gain weight. And so tamoxifen, aromatase inhibitors, and it's also just going through the whole process of your journey through breast cancer, right? You're looking for comfort, you're looking for things that make you feel better, and some people go to food. So there's so many different factors. The breast cancer in and of itself is not causing an increase in weight, but some of the things that come off of it, like the tentacles that come off of that diagnosis, doesn't help. It's messing with the hormones, the stress of going through the process. Patients have a hard time sometimes when they first start on these aromatase inhibitors or tamoxifen because it's blocking the estrogen. And so it puts you into a menopausal state if you are premenopausal from a chemical standpoint. And we all know that it's harder to lose weight. It's easier to gain weight when you're postmenopausal just because of the hormonal balances in the body. So as a side effect of going through breast cancer treatment, we have seen women gain weight.
Okay.
Which is even more important to focus on nutrition and exercise.
We're seeing some of our other, members here tonight agreeing with that, and they've seen that happen with their own diagnosis, and it can be so frustrating, right? It can be absolutely frustrating.
Right. And so I think that's important. It's a great point to bring up because sometimes you have to work a little bit harder. It's a lot because we're telling, we're all talking about it today, try to incorporate these things, and it can get frustrating when you feel like you're not making any progress. But I think it's important to know that that's why you got to try different things. And it is harder because you're dealing with something that the woman sitting next to you may not be dealing with. So they may have an easier time trying and getting success with what you're trying to do. And it's just harder for you. But that's why it's not a one size fits all. You got to try different things. And we've talked a lot about today, like what we can try to do in our life, like a lifestyle changes. But there are other resources available. So just talk to your primary care providers and your healthcare providers and see like, okay, I've tried this, X, Y, and Z. Is there anything else available to me? And have those discussions because there may be things that are available that, you just may not be aware of that is covered by insurance and that you have access to, and you have these resources, but you may not know that they exist. So it's important to have these conversations.
Yeah, we had one of our members here talk about, the frustration, and now, she honestly just doesn't know where to start. And should she see a specialist to address the obesity, because she was so frustrated that, the weight actually from the medication, the flap reconstruction started redistributing her weight. And now she feels like she has more visceral fat. So she is looking for like, where could she turn? She's no longer on medication because her cancer was triple negative.
Mm-hmm.
Do you have any feedback for her, Dr. Malik?
Yeah, I think it's really important to speak to a nutritionist because they'll have the expertise on things that you can try for someone with, your specific situation. So I would start there and try to implement those changes and things that you can do on your own. But if you feel like you're not making progress, then definitely there are medications, last resort, there's bariatric surgery. It's not for everybody, but that is an option. And so these things do, and even when you enter the bariatric surgery world, it's not like you have to end up with bariatric surgery. It's a whole process, a 4 to 6 month process where you meet with a nutritionist, a cardiologist, a lung specialist, a psychologist, because everyone has different reasons of not being able to lose weight. And they try to address all of that first before surgery actually comes onto the table. And then also in these programs, you can meet with a metabolic specialist or obesity doctor or a weight loss doctor who can then talk to you about different medications. And that's something that you can try as well.
Yeah, I'm glad you brought that up, because just hearing the frustration, hearing Tracy mention, she's the steroids and chemo, tamoxifen, gabapentin, she's tried everything. It's really frustrating. So I love that you just pointed out again that there are resources, and having that conversation with your medical team. Who else can you connect with? Who can be your support person? What are the different avenues? And not just feeling like, if you tried one thing, you have to give up, because there are definitely other options.
Yeah, it's hard to do on your own. So it's good to have like a team member, a family member, a friend that you can kind of do this with and kind of encourage each other. Different groups, support groups where everyone's like, okay, we're going to do this together. We're going to go to the Zumba class, or we're going to go for a walk in the park, or whatever it may be. Try to find your tribe and your team. I think it makes the things a little bit easier as well.
Yeah.
Yeah. We had one from Jacqueline who was just saying that can an overweight patient with type 2 diabetes and breast cancer be a candidate for the lap band or other weight loss surgeries? Do you recommend it? So again, on that same topic, it sounds like it is a full, look at the whole patient when you go to one of these professionals. So I'll let you take that one as well.
Yeah, our bariatric specialists, this is their area of expertise. And so usually women or men who are candidates for weight loss surgery, there's different types of surgery. People are candidates for different things. But one of the criteria is being in a specific class of obesity, which I won't get into too much detail with today, but also having additional comorbid conditions that are usually secondary to the obesity, whether that be high blood pressure or diabetes. And so if you are obese with a comorbid condition like that, that usually meets criteria for inclusion into someone who would be considered for weight loss surgery.
Yeah. I think we'll take one more question. There's so many in here. But Dr. Malik, maybe you can eyeball them too, and we can make sure that we're getting them in the chat, and we can post the chat as well.
I will call one out real quick, because I know Tracy asked a couple times just about clarifying, is metformin safe to take with tamoxifen and gabapentin if that is indicated by her medical team?
Yeah, I mean, I would definitely speak to your primary care physician, whoever's prescribing this, because these medications do have side effects. And so in a patient, they can be taken together, but they should not be if there are certain other situations going on. So definitely have that conversation, because blood tests and different levels in the body can affect, and sometimes the medications are given together and then the blood tests come back abnormal and one thing needs to be stopped or the dosage changed. There's so many variables that go into it. That is definitely a conversation to have with your healthcare provider.
Wonderful. Thank you.
And Erin, I saw one here from Phyllis just talking about cholesterol meds. Does cholesterol meds help? I read on a warning sheet with an anastrozole a problem with cholesterol. Not quite sure what she was asking there.
Yeah, if you look from a biological standpoint, the whole cascade, that pathway that I showed during my presentation, that this comes from cholesterol, like a lot of it is the breakdown of cholesterol into estrogen, which is not the whole picture. Because remember, there are patients with triple negative breast cancers whose cancers are not feeding off of estrogen. That's a whole nother field, but some of this data does play out and does correlate even with our triple negative patients. But that's a lot to get into today. But theoretically, yes, if your cholesterol levels are lower, then you can potentially have less estrogen. But just because your cholesterol levels are low doesn't mean that you still don't have a large amount of fat and adipocytes in the body.
Great. Thank you. Well, Dr. Malik, it was great. Thank you so much for just your attention. And it was so informative. You're getting a lot of love in the chat for sure. I do want to remind all of our members, Erin and her team of registered dietitians, they are here for you. That is a part of Unite for Her service, ongoing nutritional consults that are at your fingertips and a phone call away. So please know that we are here for you. We use that passport if you're still in our program. We can help you, just make that a little bit easier with, a coach there right by your side, helping you in that nutrition aspect of your life. So don't forget, use your passport.
Erin's going to get a lot of calls.
That's okay. And we also love, I will say, there are, but I will also say, we also love when you are connecting with your dietitian at your oncology center as well. We love to hear that. We want to also be part of that support team. So if you are working with someone already, let us know what your goals are, and we're here to help you along with it. So, we're your biggest cheerleaders, is what we always say.
Yeah. Awesome. Kimberly, you asked if your passport renews each year. We only renew if you are living with metastatic breast cancer or recurrent ovarian. If you are an early breast cancer, one of our members in those stages, then it is good for 1 year. However, the speaker series, the cooking classes, they are yours forever. You can come anytime. You can jump into Erin's class. You can jump into Michelle's class for cooking. They are there, and you get to have their voice too, right? They're live, and you get to hear everything that's going on, but ask some questions too. It's very interactive. So know that is available to you. Our website, uniteforher.org, www.uniteforher.org. Yeah.
Yep. And Dr. Malik, I don't know if you saw Phyllis. She walked on the treadmill for 40 minutes while she was listening to your presentation. So I mean, not overachieving here, but A for effort. You're making me.
Yes, you did your 30 minutes for the day. I'm so proud of you. Congrats.
I love that you said that, Dr. Malik, because I know for me personally, it's a lot of work here at Unite for Her that we're juggling. And I'm like, oh, I didn't get my yoga and I didn't get but boy, I can do 30 minutes a day. Yeah. I can do 30 minutes a day. And I think I've shared this with Erin, and I have been able to stick to it because I just lowered my expectations of 30 minutes. Everybody has 30 minutes, right?
It's
so
doable.
I think it's so important that you brought that up, and I appreciate that. Yeah. All right, Unite for Our community. I'm going to let Erin take us off here. Again, I'm going to thank our sponsors, right? West Pharma, we are so grateful for them, being our presenting sponsor. And then of course, our friends at Daiichi Sankyo and Merck and Lilly for being our supporting sponsors. And then Erin, another reminder of some of the Ask the Experts and some of the virtual hangouts that we have coming up.
Absolutely. We have a lot of great things coming in the next few weeks. Ask the Experts tomorrow, streaming live on Facebook. So no registration, just hop on 1 p.m. Eastern time, talking immunotherapy and your immune system. Next week, we have 2 things going on, actually. Virtual hangout, talking about dating and cancer with our sexual health therapist, who is amazing. And I am slipping my mind what we have. Oh, we're also our speaker series. Oh my gosh, we have so much. Our speaker series the following day is about courting. So we are bringing on a surgeon to talk about courting and a physical therapist to help with that. So we have that going on. And I also want to call out that we will also be focusing February's Black History Month. So we will be speaking with our providers of color to highlight some of those integrative services that we offer and learning from them. So much going on in February. And as Sue said earlier, they're all free to you, right? These things never use squares on your passport. They're all available on our Her library. So we've got lots of great things coming up.
Yeah, it's awesome. And you see the interaction that we have, it's one-on-one with the experts, and we will answer your questions. And if we do not know the answers, we will find them. We will absolutely find them. So again, Dr. Malik, amazing. Thank you. And everybody have a wonderful night. Thank you for joining us.
Thank you.
Thank you. Have a great night, everyone.